Top Med Talk.
Hello, welcome to Top Med Talk Down Under. I'm Andy Cumpstey, and I'm here again with my co-host Kate Leslie at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine's annual scientific meeting here in the beautiful Cairns, situated between the Great Barrier Reef and the oldest rainforest in the world, in beautiful far north Queensland in Australia. It's an amazing place to be, isn't it, Kate?
It's fantastic. It's a long way from everywhere. It's one of our speakers this morning put up a 500-kilometre radius around Cairns, and the only major city in that region is Townsville. And it's 1,500 kilometres from the capital city of the state, which is Brisbane. So they're amazing people up here. They're self-sufficient and they're really in touch with the land and the waters around Cairns. It's great.
And they know how to have a good time as well, don't they? You were out partying last night. You're going to tell us about what that was?
Well, so last night we had the college ceremony, which is the graduation ceremony for the college for our new fellows, and a couple of hundred of those went up and got their fellowships presented to them by the president. And then we awarded fellows and other people special awards, the Robert Orton Medal and the Ansgar Medal. And then we had a terrific oration from Kevin Phuong, who's always entertaining and inspiring. And he talked about, failure, actually, and he failed to get selected to astronaut school, which is, in the pantheon of failure, something that doesn't seem that bad. And he was terrific. And then there was a reception afterwards. So it was a great evening.
And I remember thinking this last year at the Brisbane annual scientific meeting, but I think it's a really special thing that Ansgar and the Faculty of Pain Medicine do by bringing that celebration evening into this event and making it all part of the celebrations, really.
It's always been part of our conference. I mean, we have an ulterior motive, which is that we want to engage our newest fellows in our annual scientific meeting, and we offer them free registration if they attend the college ceremony, and then they get hooked. And they come back year after year, and then they're speakers, and then all of a sudden they're the president of the college before they know what's happened. Yeah.
Fantastic. Well, that segues nicely into two fantastic talks we had yesterday, and we're very honoured to have both those speakers here with us today. So we've got Ramani Moonesinghe, who's a very familiar face in the UK and also a well-known voice on Top Med Talk, and also Phuong Markman, who's here from Cairns and gave some fantastic insights yesterday about Sip-Til-Sen, which we're going to pick him up on later. But ask you both to introduce yourselves, tell us a bit more about where you're coming from and what you've been doing in the last couple of days.
Thanks, Andy. Yeah, good morning, everyone. Ramani here, and I've flown over from Sussex in England. I work in London at University College London Hospitals and UCL University, and I've got a couple of leadership roles for the NHS in England as well, for patient safety and for perioperative and critical care. So I've come over on the invitation of the college. I'm very grateful to the college for having me over. And I've been talking about a few different things, but one thing about sort of health inequalities and some work that we're doing to try and reduce inequity of surgical outcome because of socioeconomic deprivation. And another one which sort of touched on innovation, which keeps with the theme of the meeting about being future-proof. So maybe we can talk a little bit about that.
Yeah, brilliant. We'll come back to both of those things, I'm sure. And Phuong?
Oh, good morning, everybody. My name's Phuong, and I'm a local from Cairns. And I'm originally a Melbourne boy, but through a long-winded journey, I've ended up in a place that I'm very, very happy with. It's wonderful to work up here in the Department of Anaesthesia, Perioperative Medicine. I'm the head of research there in that department, and also I run the Australasian Sip-Til-Sen network. And currently the biggest project we've got going there is the Australasian MAR study that will hopefully find an answer to the aspiration risk with Sip-Til-Sen.
Perfect. I think we'll come back to both of those topics a little bit later too. But first, I'm going to come back to you, Ramani. So you gave us two fantastic talks yesterday. As you mentioned a little bit about innovation initially, why don't we look at that one first? That was one of the plenary sessions you gave. And I think you touched on the crisis that we're facing in the UK at the moment. But I think gave us some really inspirational perioptimist sort of views forward about hopefully some ways out of that crisis. But if you want to summarise some of that for our listeners at home?
Sure, thank you, Andy. So, I mean, I think it's like so many countries that were hit hard during the pandemic, we've got a big problem with waiting times for surgery, for elective surgery, and huge numbers of patients waiting for both surgery and also for outpatient appointments, which might ultimately end up with them needing a procedure. And then on the other side, we've got a huge problem with our sort of urgent and emergency care, so patients waiting a long time in accident and emergency departments to be treated and all those sorts of things. So the totality of it is that we're kind of, it feels like we haven't got quite enough capacity to treat the demand in the NHS at the moment, and we're quite often not using the capacity that we do have to its best advantage. You know, we're not using the resources that we do have efficiently and as productively as we could. So we're doing tons of different things in the UK to try and address those problems. Some of it's about pathway innovation. So in the case of surgery, and this is not a new theme for perioperative medicine, trying to get patients ready for surgery, fitter for surgery. Our Centre for Perioperative Care has coined that phrase about using waiting time as preparation time. So doing all of that stuff. But alongside that, some digital innovation as well. And so to enable that optimization to happen, we're doing more and more about trying to connect up primary and secondary care pathways, using often digital tools to enable us to do that, trying to suck information in from primary care records into secondary care so that we can take a bird's eye view of the patients on the waiting list at their individual problems and then try and treat them. And then alongside that, there's stuff that we're doing in other bits of the pathway as well. For example, some more exploratory work, but some that's being done in our hospital in London around using wireless wearables. So, you know, we've all got Apple Watches or similar Fitbits, whatever, that count our steps and nudge us into being more active and all of those sorts of things. But there are now increasing numbers of wireless wearable technologies that we can use to monitor physiological status, and that are actually, you know, medical devices. So we're doing work both to try and see what the place of those might be in reducing ICU admission and even enhanced care admission, seeing if patients can be monitored on normal wards with those sorts of technologies. And something that I'm very interested in looking at is what we can do in terms of looking after patients after they've been discharged from hospital, using those sorts of technologies. It might facilitate earlier discharge, and that might be really good for some patients because they want to get home, they don't want to be in the hospital. But it also, even more excitingly, might provide us with a means of monitoring patients so that we can pick up deterioration earlier, just in the same way as we do in the hospital by doing regular observations and early warning scores and all those things, actually extending that out into the community. And if those sorts of things do work, and I do say a big if because they all sound like great ideas, don't they? But we don't know if they'll actually make any difference. Then it may be that they also help to narrow some of those health inequalities that I talked about in my second lecture, because people from more deprived backgrounds, people who are not very health literate and those sorts of things, need that extra little bit of support when they're at home.
I was astonished to learn from your lecture about the degree of socioeconomic deprivation in England. I had no idea really that it had got that bad, or that it had been that bad for a while. Can you explain to our listeners the data that you presented to us about that issue? There were very interesting urban, regional and north and south variations.
Yeah, absolutely. And this is a problem that has existed in the UK for a very, very long time. Probably the most well-known academic looking at this is someone called Sir Michael Marmot, who was a professor actually at UCL, where I'm based. And he founded the Institute for Health Equity there. But he's studied the epidemiology of socioeconomic position in the UK for many, many years. And what we see is the impact of deprivation, and you can measure it in multiple different ways, and we can maybe talk about that. But the impact of deprivation on life outcomes is absolutely staggering. So the difference in average life expectancy for men living in the most affluent areas versus the least affluent areas is 20 years.
20 years?
Yeah.
Wow.
And there's a difference in absolute life expectancy, and there's also a difference in healthy life expectancy. So what we see is when patients present for surgery, if they are experiencing the impact of deprivation, they may be 10 years younger than the average patient coming for the same sort of procedure, but their health, their biological age is the same or older. So it's a massive problem, and it's one of those things, if you don't look, you don't necessarily see it.
I think you also said, though, that some of the most deprived people in the UK are lucky enough to get care in some of the most important and influential university hospitals.
That's
just
right.
by quirks of history, really.
Yeah, traditionally, I suppose, big university hospitals have been generally located in inner cities. And inner cities are often the places where you've got very high concentrations of socioeconomic deprivation as well. But that relationship isn't always true. So our chief medical officer is very keen to emphasise the challenge of people in poor coastal communities. And the other thing that is really fascinating is there is a separate geographical effect of deprivation. So if you're a person living in a poor neighbourhood in the south of England, your life outcomes are still a bit better than someone living in an equivalently poor area in the north of England. So there's a north-south divide, which we talk about and we sometimes sort of laugh a little bit about in the UK all the time, but it's a very real and not a laughing matter problem when it comes to the impact of deprivation.
So I don't mind confessing, I grew up in the north of England in Blackpool, and I now live in the south of England in Southampton, and I see that north divide every time I go home. So it's interesting, Kate, that you see that as a surprise, but I wasn't surprised by Ramani's data yesterday at all. But the fact you see it as a surprise, is that a UK-only phenomenon? Is there a similar thing in Australia? I mean, you work in a busy university hospital in Melbourne, one of the largest cities in Australia. And then, Phuong, you're here in Cairns in a smaller department with, 20, 30 full-time anaesthetists?
Yes.
So in Australia, the main issue when you look at comparing Australian health services with international services, we rank really well on all different metrics except for access.
Right.
And that relates to the fact that we're a bit like Canada. We're a very large country with a group of people that are all within 100 kilometres of the coast. And there are large areas of the country where people have very poor access to urgent care. And we have a lot of poverty in Australia, in rural communities. And also in cities. And then we have the health issues that are faced by our Indigenous people. It's widely known that their life expectancy is lower than ours, and there have been concerted efforts over many decades by all the governments on all sides of politics to address that. But Phuong, you're in Cairns, in an area with a large number of Indigenous people, but also those access issues that we talked about remoteness. How's that experience been for you?
Look, not coming from a background with data to show, but I am convinced that access and the distance to services, not just healthcare services, is a very big correlation to the level of poverty and the level of general health and well-being. So I think we see that perhaps with a little bit more emphasis in a more remote location here when you compare people from even inner city versus those in the more remote satellite areas in the far north. And yes, so I don't know whether in England those same distance geographics play such a role.
They definitely do. But of course, the distances in England are microscopic compared to out here.
Yes. It's perhaps all relative, but in Australia, we're pretty well known for being so spread out, aren't we?
Yeah, absolutely. 1,500 kilometres, you said, between here and the capital of the state. I mean, that blows my mind.
Cairns, Melbourne it to Brisbane is the same as Cairns to Brisbane.
In fact, I'll trump that. Now,
Yeah.
most tourists get into this trap. They'll come and they think, oh, I'll go to Brisbane and I'll just drive north to Cairns. How far can it be? Big mistake.
Yeah.
Actually, that distance from Brisbane to Cairns, and I've measured it, is actually further than from Melbourne to Brizzy.
Yeah.
So in the implementation of your SIP to Send program, you must have needed to communicate with patients preoperatively and assess them and bring them up to speed with the ideas about fasting and preparation. In Cairns, do you bring patients in for in-person pre-admission assessment, or
Absolutely.
do you have telehealth services or outreach services of some sort?
The lion's share of the preoperative evaluations are done face-to-face. We do have a very good triage system whereby our nursing staff, and we have a very good nursing staff in our preoperative clinic, who will do telephone consults in those lower risk patients who will be able to sort it out over the phone. And occasionally you'll have to get an anaesthetist's opinion as to medication advice, when to stop something, and that's where the only interaction we'll need for those sort of situations. But yes, we do bring a fair amount of our patients in for a face-to-face consult.
And moving on to your SIP to Send program, can you just remind our listeners what SIP to Send is?
Yes. Well, SIP to Send, I guess, is the modern day rebranding of what is not new. It's the idea of allowing patients to sip or drink right up until they go to theatre without a arbitrary time limit slapped onto it. And the idea is we're trying to fight this half a century's old notion of fasting from midnight, which didn't delineate fluid from solids, and that left us in a situation where people don't drink for way too long. If you're doing the measurement of average fluid fasting times, you get about 7 hours plus or minus, and that plus is the key. Half of your patients are fasting longer than that, and you'll have patients fasting way beyond 12 hours. All well and good, but if you compare that to pain management, in pain management we've developed a fairly widely accepted system of patient-controlled analgesia, whereas here we've been not allowing patients to have their own patient-controlled hydration. So we've been leaving people dehydrated. So SIP till Send allows them to sip clear fluids, and that ranges, it depends on which hospital you're from as to what that actually is allowed. But generally it's water plus or minus a few other clear liquids.
And how did you get your national SIP to Send? I'm saying it wrong, aren't I? SIP till Send.
Yes.
How did you get that up and running? And what barriers did you need to overcome?
By the way, it's a deliberate spelling mistake. Till here is T-I-L, not double L. So just to clarify that potential confusion point. So it got going because deep down we all realised people weren't fasting for way too long. We just didn't know what to do about it. I think it was around about the time Dr. Matthew Checkett's from Scotland came over, and after their quality improvement program, SIP till Send, was launched and showed some good data that they were able to drastically reduce their fluid fasting times. He presented that to some groups in Australia, and that just struck a chord, and that set off a whole wave of interest, which was widely communicated. So at that time, Dr. Phil Black from Prince of Wales almost gave me a cold call. And he said, "Oh, have you heard about it?" And I said, "Yeah, just recently I'd heard that podcast that Dr. Matthew Checkett had done. It's still available if you're interested." And we just got going and talked what we should do about it. And the idea is you've got all these people interested in it. Clearly you want to make a difference. Yet there's a lot of unknowns, and it's a very tricky thing. We're trying to go against the grain of an institutionalized thinking that's been there for half a century. How do you do it? Well, the answer is to collaborate. And so we formed this thing that is now called the Australasian SIP till Send Network. And basically, it's run off an MS Teams group, actually, and it's there to share the resources of all the hospitals that have already done it, so that the ones who are interested in doing it have that ready access. It's the guidelines that have been written. It's the patient promotional, educational things that have already been developed, rather than getting everybody to start from scratch.
We've had a SIP till send program implemented at my hospital, the Royal Melbourne Hospital, and that's through Dr. David Moore.
Yes.
And it's going really well.
Yes.
One of the main barriers is that the patients are not drinking. And that's because they're experienced patients. And they want to maximise the chance that they're going to get their operation.
Yes.
And they know that there's variation in what anaesthetists are comfortable with,
Right.
even if it's the hospital policy to do SIP till send.
Yes.
And they're not sipping their fluid. What have you done and heard and learnt about that?
I think it's an awkward. We're still at that awkward developmental phase of this transition, aren't we? Where not everybody's convinced, and patients are still doubtful themselves, and that's understandable. I think once we get more data and we can all be convinced, then the patients will be less concerned of this individual variation in the people treating them. So I think it will come in the form of if we can unify the message that it's okay and it's safe, when we can actually say that for sure, that it's safe for them to sip. The other thing, Kate, is that just because a patient doesn't drink, that's not a bad thing. We're not here to waterboard them and force fluid down their mouth. We're here just to offer them something that will prevent dehydration, such as I drew this analogy earlier on, pain management. If they're not sore, they're not going to ask you for opioids. We don't force it on them. Why force fluids?
Yes.
But it's there for them.
That's a good attitude. Yeah. Ramani.
And we're all anaesthetists, we're very precise people. What does SIP mean? Like, if the patient was to down a pint of water,
Yeah.
would that raise any alarm bells? Would half of your colleagues cancel them?
It's the message is there that you shouldn't scull.
Yeah, okay.
Unfortunately, whenever there's a message, it never always gets through. We're not sure what to do about those who just scull, to be quite honest with you.
Yeah.
I think most of the time, there's enough time elapsed after that we don't think it matters.
So do you give patients 30ml cups?
Well, typically it's a typical ward cup, which range from 150 to 200 mils in most hospitals. And at Cairns, we just took a pragmatic approach. We didn't want to introduce new cups. I went around looking at what cup volumes were, and that was the volume we used.
And again, so I think Ramani's hit the nail on the head in some ways, but when we talk about barriers, it's not just the patients, but it's us as well as clinicians. Sometimes our barriers in these systems, and I know there'll be a lot of people at home listening to this or online listening to this concerned about aspiration risk if they're getting their patients to sip until the point of sending to theatre.
Yes.
You gave some very nice, reassuring data about that in your talk yesterday.
Well, as reassuring as we can be with such a difficult data point to achieve, which we're working on, and I'll get to that. But I think the key is initially to get your colleagues on board. And it's not propaganda, it's simply just informing them in a space where they previously perhaps did not think very deeply. And so what my first task was, I actually wrote an info leaflet that was a 2 A4 sided. I just left in the tea room and I sent it to all my colleagues. And after that round, plus a few verbal presentation things, we then surveyed the department. And this is a popular approach. Phil Black at Prince of Wales did the same thing way before we did, but we ran with that idea. And then we surveyed and got a very high accepting response. In other words, we had 97% of our anaesthetists agree to do SIP till send. Once you got your core group on board, then you start doing similarly to other stakeholders in the hospital, starting with the surgeons and then nursing and beyond.
But I think it's important to really reinforce that except the data we've got is limited, and we'll come on to that in a second, but the data we've got doesn't suggest this increases aspiration risk.
Yes, so there's 2 to 3 published studies which show that the aspiration rates were akin or similar to that of more restrictive fasting groups.
But as we said, that data's not perfect. And do you think you've got a solution to that?
Well, the problem is it's underpowered. And to be adequately powered, we've done the number crunching. You do need around 125,000 patients per arm. That's the septal send arm. In other words, you need around 250,000 patients to answer the question as per our definition of aspiration.
That sounds like one of those studies that needs either a sort of causal inference approach, so you just use routine data and analyse it and see, or there's some great work being done by colleagues of mine to embed randomisation into electronic health records. And, you know, this is an interesting one, right? Because if you talk to patients about it, and this is not a new drug or something like that. It's a very patient-friendly intervention. And there is natural variation between colleagues, so it's the perfect one just to study in a sort of natural experiment kind of way, isn't it?
I think you and I have to get in touch, Ramani, about this. Look, Dr. Ruth Blank is another anaesthetist. She's my co-lead in this study that we called Australasian Mars. We have found it very tricky to convince ethics, well, not convince, but to work through the ethics and the data policies aspects of extracting the data. In the first place, and I'm hearing your work in England of being able to extract primary health data from the records. I'm in awe of what you're able to do, or indeed intend to do, because we have found it very tricky, because there are jurisdictions you have to work with, and when you want to do a national version of that, there are umpteen different policies that you have to read through.
Yeah.
You were talking about gadgets and widgets and things before. I was imagining as you were speaking that we could have robotic healthcare assistants or research assistants that would be wandering around wards going, would you like a drink of water? And they'd be measuring the amount that people would be taking, and they'd be going, don't pick up that muffin or we'll cancel your surgery, that kind of thing. All sorts of ways that we could help patients. Do you imagine, had you gone that far in your imaginings about the future?
Yeah, I mean, I think, we're already using chatbots more and more in healthcare. So there's a chatbot company in the UK that now uses a chatbot to follow up patients after routine eye surgery. And this is a particularly interesting one, right? Because these are predominantly very elderly people who have come to have their cataracts or their glaucoma treated surgically. So you could think, these ones are the least likely to want to be followed up by a chatbot, but in fact they love it. And the chatbot can phone 100 patients simultaneously and then have a conversation with each of them simultaneously. And it follows a very risk-averse algorithm. And the patients love it, and it saves money, and you don't need a nurse, and very few of those patients need a medical intervention to follow them up. So that's a telephone chatbot, but I mean, your little HAL robot that's wandering around serving the patients 60 mils of water, 100 mils of water at a time is not far off, I don't think.
You've given me a fantastic idea. My next funding proposal for the hospital is to get one of those robots that I've met at a Japanese restaurant recently that served me my drink.
Exactly.
Excellent, thank you.
I think sadly we're slightly running out of time. I could carry on this conversation a lot longer, but just to finish, I know you finished yesterday, Phuong, with your talk about the Mars trial. I know you're keen to generate interest and recruitment for that. You want to give a bit of a plug for that?
Thanks very much. Yes, so MARS stands for Multi-Centre Aspiration Risk Study. It's multinational, actually. It's New Zealand and Australia. We've got 40 hospitals recruited at the moment, and that will bring us a study that will complete in about half a year. We're always interested in more hospitals joining. We'll open up a further round of recruitment soon. Basically, we will be looking at both the hospitals that run septal send and also those that don't, or don't yet. And we'll amalgamate that data to compare the number of aspirations and then look at the entirety of their anesthetics that they've done for the whole half year and work out a numerator divided by the denominator. It's as simple as that.
And how would a hospital get involved with that if they wanted to?
They can email either Ruth or myself. We can provide the links to the email.
We'll put that in our show notes.
Fantastic.
Thanks, Andy.
Well, I think that's a good way to finish and heading to Mars. As always, you can find us on our app, on our website, and on social media. Make sure if you do find us on social media, we're on Facebook, X, Blue Sky, and YouTube. Do give us a thumbs up. Do hit subscribe. It really does help us. And finally, as always, we really want to thank our sponsors. That's BD, GE, and Solventum, without whom we couldn't bring Top Med Talk free and open access to the world. thank you both for a fantastic session, and look forward to next time.
Thank you. That was great fun.
Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.